Next on the agenda, we have a symposium on healthy kidneys for future. To chair this symposium, I kindly invite Dr. T. Perandaraja, consultant physician, and Dr. V. Bhavandan, consultant nephrologist.
Good morning, everyone. I am Dr. Bhavandan, and we have here Dr. T. Perandaraja, a senior consultant physician. It's our great pleasure to moderate this nephrology session called Healthy Kidneys for Future. First of all, I would like to extend a very warm welcome to all of you. Thank you very much for excusing your time to join with us today. So, you know, the kidney disease is very common nowadays, and most of the patients come to us with end-stage renal failure. So, it is vital to identify the risk factors for kidney disease and prescribe appropriate medications. Today this session will talk about this, and I will share that you will be furnished with all the information. Before we begin, I have a few housekeeping notes. So today we have 3 presentations. So each presenter in this session will have around 15 minutes of time for their presentation. After all these 3 presentations, there will be a time for question and answers. Now, let me introduce our first presenter, Dr. Rajitha Abesahara. He is a gold medalist in MD Part 1 and Part 2, and he holds a degree in MSc in statics. And he had multiple publications. In addition to that, he is a national representative of badminton. At the moment, he is working as a senior lecturer and specialist. He is a specialist in renal medicine, Department of Medicine, University of Peradeniya. So I would like to welcome first presenter Rajitha, and without ado, I would like to ask Rajitha to deliver his presentation.
Good morning, everyone. I would like to thank the Jaffna Medical Association, the President and the Council for inviting me to give this presentation at your annual conference this year. So let me share my screen. So the topic that has been asked from me to be discussed with you is on management in diabetic kidney disease. And as you know, diabetes is becoming a huge problem globally as well as in our parts of the world. And in order to discuss diabetic kidney disease, I'd like to start off with discussing a typical case scenario you and I would encounter in our day-to-day practice. So it's a 58-year-old type 2 diabetic patient for the last 15 years with hypertension for 5 years, and he's an ex-smoker. His blood pressure is 160/90 millimeters of mercury, and he's on losartan 25 milligrams MANE and HCT 25 milligrams MANE with a BMI of 32. His HbA1c is 9%, while he's on Metformin 1 gram BD, sitagliptin 100 daily, and he has an eGFR of 38 and a urine ACR of 200. So before we go on to discuss his case, we'll first move on to talking a little bit about diabetic kidney disease. And as you know, diabetes has a global incidence of approximately 460 million in year 2019, and it is estimated to go up to 700 million by 2045. And when the diabetic numbers go up, so does chronic kidney disease. This is data from the US ARBS database in 2018, where it looked at causes of CKD in the US population. And as the graph shows, diabetes has remained the biggest causative factor for chronic kidney disease. And the other side of the story is that whenever you have CKD proportions going up, you have increased mortality and increased mortality, morbidity, and cardiovascular disease. And lower the kidney function, higher the mortality becomes, higher the albuminuria, higher the mortality becomes, and higher the cardiovascular disease burden as well. And this is much more significant among the diabetic populations compared to the non-diabetic populations. So how do we diagnose diabetic kidney disease? It's a clinical diagnosis in the majority of the patients, where you have a history of long-standing diabetes with associated microvascular complications, typically diabetic retinopathy, proteinuria with a urine ACR of more than 30, and low kidney function with a GFR of 60. So in combination, all of these would constitute a diagnosis of diabetic kidney disease in the majority of the patients. However, if you want to have a definitive diagnosis, renal biopsy remains the gold standard. However, we do not perform biopsies in the majority of the patients because it can be very reliably diagnosed with the clinical presentation. However, it's very important to understand the natural history of diabetic kidney disease. And traditionally, it has been said that at the onset of diabetes, you have functional and structural changes where you have hyperfiltration, proteinuria, and slight increase in the kidney size, with structural changes of glomerular basement membrane thickening and mesangial cell expansion, which happens over the initial few years. And by the time they reach about 2 to 5 years period, then you start developing early clinical nephropathy features with microalbuminuria and gradually increasing blood pressures, which progressively gets worse over the next few years. And then with time, the proteinuria gets worse and you start getting renal kidney function impairment with rising serum creatinine. And this progresses to end-stage kidney disease. And this has been the traditional teaching and the traditional way we have looked at diabetic kidney disease. However, we now know with multiple evidence and studies showing that not all patients progress through these typical stages in diabetic kidney disease, and a lot of patients have deviations from this. There are patients who present only with creatinine increases with no evidence of significant proteinuria. And at the other end, you have a significant proportion of diabetic patients with significant proteinuria and even nephrotic syndrome with minimum renal function impairments. So there is a wide variability on the phenotypes, and this is a changing paradigm that you and I should be aware of when managing patients. However, it's very important to keep in mind alternative causes for kidney impairment. And this should be suspected, especially if there is no evidence of microvascular complications such as retinopathy, if a patient has active urinary sediments with microscopic hematuria or red cell carcinoma, or if the kidney functions are worsening in a rapid manner, like rapidly worsening proteinuria, rapidly reducing GFR, which is not in keeping with the normal progression pattern of diabetic kidney disease, or if there's evidence of systemic diseases such as vasculitis, lupus. In that background, in a diabetic patient, if you have impaired renal function, you should consider other alternative causes. And in most patients, this would warrant a kidney biopsy. A simple word about the distinction between diabetic kidney disease and diabetic nephropathy. So earlier, we used to very loosely call this entity diabetic nephropathy. However, now we know that in a patient who has diabetes and chronic kidney disease, there are other pathogenic mechanisms that might be contributing to this underlying chronic kidney disease, such as hypertension, renovascular disease, atherosclerotic disease. So it's very difficult for us to clinically tease out each component. So in order to incorporate all of this, a broader term like diabetic kidney disease is now used to identify these patients with diabetes and chronic kidney disease. However, if we have histological definitive diagnosis of diabetes related kidney problems, then we use the term diabetic nephropathy. So I'll focus more on the management aspects of these patients. And it has been a very exciting last decade in the management of diabetic kidney disease. And incorporating all these evidences, the KDIGO guideline in 2020 put out these practice guidelines for the management of diabetic kidney disease. And the KDIGO is the international body which puts out these guidelines, and we are governed by these guidelines in the management of diabetic kidney disease. And there it was very strongly emphasized the importance of comprehensive care in the diabetic patient in the management of diabetic kidney disease, which includes glycemic control, RAS blockage, blood pressure control, lipid management, lifestyle activity modification, smoking cessation, nutrition, and also antiplatelet therapy for cardiovascular disease prevention. So if we first concentrate on the glycemic control, the target for glycemic control has been loosened a little bit, where we now talk about the target range of less than 6.5 to less than 8%. And on this axis, and you can see the 6.5, here you can see the 8, and you have to take a lot of individual factors when deciding on a particular target for an individual. For example, if a patient has, person is very young, has a long life expectancy, and also has low risk of hypoglycemia, there it's very, very important that you target a very stringent control of less than 6.5. Whereas if it's an elderly person with very short lifespan with high risk of hypoglycemia, there you have to loosen your glycemic control targets to less than 8%. And very importantly, the targets needs to be individualized. When talking about therapeutics, metformin has remained and is remaining as the first-line agent for the management of diabetic kidney disease and is recommended in all patients with a GFR of 30. However, it's very important that GFR is monitored and dose adjusted according to the GFR targets. And when the GFR falls to less than 30, metformin needs to be discontinued due to the risks of lactic acidosis. It is also recommended to look for vitamin B12 deficiency, especially in patients who've been on metformin for a long period of time. And also metformin is advised to be withheld during episodes of acute kidney injury, critical illness, and contrast use due to the risks of worsening lactic acidosis. The last decade show a lot of clinical trials being put out, especially in looking at SGLT2 inhibitors, DPP4 inhibitors, GLP-1 agonists, and you can see starting from EMPA-REG, the leader trial, there has been a whole heap of trials that has been done and which has shown promising results. And of that, I think it wouldn't be wrong for me to say SGLT2 inhibitors has been the key front-running drug which has revolutionized the management of diabetic kidney disease. EMPA-REG trial, Canvas trial, DECLARE-TIMI, Credence, and even now the the DAPA-CKD trials, all these very convincingly showed that there is reduced risk of progression of renal composite endpoints as well as cardiovascular endpoints have been significantly improved by the use of SGLT2 inhibitors. In whatever we look at, this is a meta-analysis of the major clinical trials on SGLT2 inhibitor, in which way we look at whether it's end-stage kidney disease, in the reduction of the doubling of kidney function, proteinuria. All these studies showed significant benefit by using SGLT2 inhibitors, and SGLT2 inhibitors are now here to stay in the management of diabetic kidney disease. It's important for us to know a few things when using SGLT2 inhibitors. The current trials have all used SGLT2 inhibitors in patients with a GFR of 30, with the exception of the DAPA-CKD trial, which went down to a GFR of 25. So generally, the use of SGLT2 inhibitors are recommended to be initiated when the GFR is more than 30. And due to the mechanisms of action, it's recommended to withhold during times of prolonged fasting, critical illness due to the risks of euglycemic ketoacidosis and acute kidney injury, And in patients who are at risk of hypovolemia, this needs to be corrected prior to initiation of SGLT2 inhibitors. And also very important practical point is this initial dip in GFR that most of us would see when initiating SGLT2 inhibitor. So here in this graph, you can see SGLT2 start of SGLT2 inhibitors versus placebo. And you can see the moment you start it in the first few weeks, you will start seeing a dip in the GFR. And most individuals get scared by this and stop SGLT2 inhibitors. But please be reassured that this is a normal phenomenon of the action of SGLT2 inhibitors and is accepted. And after, in the long term, you can see crossing by the time the 1 year mark it crosses. And overall, in the long term, the kidney function decline is much less compared to a placebo when using SGLT2 inhibitors. Moving on to the next group of drugs is your GLP-1 receptor agonists. And again, I'm showing here a meta-analysis using the big trials that had looked at GLP-1 receptor agonists, Alexa, Leader, Sustain, Rewind trials. And again, all of these showed significant benefit with composite kidney outcomes, including reduction in proteinuria and worsening kidney function. And most of these studies showed significant benefit and favored the use of GLP receptor agonists in the use. How do GLP-1 mediate this action? It has both direct and indirect actions where it causes hemodynamic alterations, the anti-inflammatory effects, the reduced oxidative stress, the inhibition it has on the RAS pathways, and increased natriuresis, providing beneficial action on the kidneys. And indirectly, the glycemic control improvement, reduction in blood pressure, and the weight loss have also been postulated to result in this benefit by use of GLP-1 receptor agonists. So incorporating all of this, the KDIGO guidelines now recommend this in the use of diabetic kidney disease, where after your initial basic management, Metformin and SGLT2 inhibitors are considered the first-line treatment to be initiated in any patient with diabetic kidney disease with a GFR of more than 30. And once that has been initiated, then you can keep adding on any medication depending on the requirement. However, GLP-1 receptor agonists have come as the next line preferred medication to be added on to these therapies. So this is the current guideline that is recommended for diabetic medication in diabetic kidney disease patients. Moving on to blood pressure control. Now, over the years, there have been many guidelines being put out for blood pressure control, and the blood pressure targets have really, not changed significantly, but has always been wavering between 130, systolic 140, and diastolic between 80 and 90. And some of the renal guidelines in the past was taking the proteinuria also into consideration when giving rise to this, when putting forward targets. However, now amalgamating most of the guidelines together, irrespective of the proteinuric situations, the blood pressure target on average of less than 130 by 80 is recommended. However, the renal specific guidelines have gone one step further from the blood pressure hypertension targets to recommend to target a systolic blood pressure of less than 120 millimeters of mercury using standardized office blood pressure measurements in any patient who's tolerating this degree of blood pressure. And with regards to the choices, ACE inhibitors and your angiotensin receptor blockers have remained the first line, with mineralocorticoid receptor antagonists also showing a lot of promise during the recent trials, which I will talk a little bit in my next few slides. So ACE inhibitors, angiotensin receptor blockers, as you know, with a lot of evidence and with a lot of practice and experience, has remained the first line due to many reasons. It reduces proteinuria, reduces the progression of proteinuria, it has antihypertensive properties, and has also a lot of cardiovascular benefits by the use, and remains the first line in the treatment of these patients. A few practical points. It's always important to achieve the maximum tolerable dose of these ACE inhibitors or angiotensin receptor blockers to get the best benefit from a diabetic kidney disease point of view. And the combination of these two groups is not recommended due to the risk of hyperkalemia and acute kidney injury. And just like in SGLT2 inhibitors, when starting ACE inhibitors, there can be a rise in serum creatinine to 25 to 30%, which can be acceptable. But this needs to be monitored after initiation after about 2 to 4 weeks to make sure it doesn't get worse than this. If it's going higher than 30% increase, then you should withhold it or look for other causes of acute kidney injury. Another aspect to blood pressure control is this common question that has been asked is, would ACE inhibitors and angiotensin receptor blockers be recommended in the use of diabetic patients with proteinuria with normal blood pressure? And these two studies, the Renal study and Innovation study, had a small group of patients who had normal blood pressure. And in both studies, it was convincingly showed that despite normal blood pressures, they would still have a clinical benefit by use of ACE inhibitors and angiotensin receptor blockers in the management of diabetic kidney disease. So after the 2020 guidelines came about, even after that, we now have more evidence and more new drugs that are showing benefit in diabetic kidney disease, and that is mineralocorticoid receptor antagonists. And the Fidelio DKD trial, and recently a few months back, the Figaro trial, which looked at Renal, which is a non-steroidal mineralocorticoid receptor antagonist, which showed significant benefit in reducing the risk of CKD progression and in reduction of the cardiovascular morbidity and mortality. So now these medications are also coming in a big way into the management of diabetic kidney disease. Apart from this, all other measures that we take for the management of chronic kidney disease, like avoidance of nephrotoxics, prevention of dehydrations, avoid smoking, aggressive treatment of any infections, especially urinary tract infections, maintaining ideal body weight, maintaining physical activity, considering antiplatelets for cardiovascular disease benefit, nutrition, and also very importantly, timely referral to nephrology services are very important for these patients. And finally, no matter what we do and what we tell the patient, a self-management program needs to be started in all these patients, where the patient becomes self-independent, understandable about their disease and the management of their disease and the medication. So finally, going back to our patient, where this patient has long-standing diabetes. So how can we optimize the management with the latest evidence that we have? So in regards to lifestyle modifications, we can recommend him to lose weight and continue to not smoke and to reduce the salt intake. With regards to diabetic and proteinuria management, the metformin dose is currently at 1 gram BD and he has a GFR of 38. So this has to be reduced. And we can consider starting SGLT2 inhibitors with the current evidence we have, and also consider adding a GLP-1 receptor agonist. And in the blood pressure control and proteinuria management, you have to continue the RAS blockage. But as you can see, the maximum tolerable dose is not achieved in this patient. So we have to increase the losartan to the maximum tolerable dose and try to aim a blood pressure of 130 by 80. And if he's tolerating this, go down to even a systolic blood pressure of less than 120. And at the same time, we can consider non-steroidal mineralocorticoid receptor antagonists as well, provided the potassium and other things are stable. So finally, the take-home messages are diabetic kidney disease is common, and the phenotypes of diabetic kidney disease is changing now compared to what we saw and what we knew before. However, it is preventable and controllable if timely intervention is taken. And we now have very good new therapies to minimize progression and improve outcomes of these patients. And blood pressure, blood sugar, and proteinuria management are the key to minimize progression and improve the outcomes of these patients. Thank you.
Thank you very much, Dr. Rajita. for enlightening us on management of diabetic kidney disease. It's time to introduce our second speaker, Dilukshi Vijayaratne. She was graduated from the Faculty of Medicine at the University of Colombo with the first class honors. She was board certified as a nephrologist in 2020. Thereafter, she joined the Department of Clinical Medicine as a lecturer in 2020. So over to you, Dr. Dilukshi, and the topic is updates on glomerulonephritis.
Good morning. I hope you can see my slides. I'm Dilukshi Vijayaratne. Thank you very much for giving me this opportunity to deliver this talk at the Jaffna Medical Association. Today, my task is to talk about updates in glomerulonephritis. And fortunately, there was very recently a guideline that came out issued by the KDIGO, which I'm going to refer to in my talk. This is a very long guideline with over 200 pages, and I tried to extract what I think is relevant to a non-nephrologist audience so that it will be useful to the listeners. So this is the outline of my talk. I'll be focusing a little bit on new diagnostic approaches first, and then I will talk about some management issues. With regard to general management, I'll be speaking about anticoagulation and then some specific cases in lupus nephritis and ANCA-associated vasculitis. So let's start with the diagnostic approach. We're all familiar with the traditional approach to kidney biopsies, where we focus on the morphological diagnosis. For example, if you do a biopsy in a patient with nephrotic syndrome and the glomeruli are normal, on light microscopy, we will say this could be minimal change disease. Or if the glomeruli show diffuse proliferative changes, we say this is diffuse proliferative glomerulonephritis. So we diagnose based on the pattern. And our usual format is looking at light microscopy to see what the pattern of injury is, and then supported by immunofluorescence, EM if it's available, and then in some instances, genetics. So the current trend is to focus more on pathogenesis rather than morphology. And the reason is that we have begun to understand that going by the morphological diagnosis often leaves us a bit stuck because we don't understand what exactly is going on in the kidney. Now, the perfect example for this is our new approach to membranoproliferative glomerulonephritis. And this is from a few years ago, has been brought up in the recent guideline. So membranoproliferative GN, if we call a particular glomerulopathy membranoproliferative, it is a morphological diagnosis. We are making that diagnosis based on what the glomeruli look like under the microscope. So the glomeruli look lobulated, there are some proliferative changes, there's some thickening and double contouring of the membrane. And if those features are there, we say this is membranoproliferative. But there are many causes, many etiologies which can lead to this kind of pattern of injury on a glomerulus. And there are many different disease mechanisms. So this is in short a very heterogeneous condition. It's like saying somebody has anemia. When we talk of anemia, we know it's a syndrome, it is not a diagnosis. So if we want to treat, we need to find out what the etiology is. So the old classification tried to classify membranoproliferative glomerulopathies based on electron microscopy. So they tried to localize where the immune deposits were and then categorize as type 1, 2, or 3. But this classification was also not very helpful because, again, it didn't tell us enough about what the underlying disease process was. Now we have a new classification for MPGN, which is based on the immunohistology. So immunohistology can be using immunofluorescence techniques, like you can see here in the pictures, or immunohistochemistry. Now, when we do immunofluorescence, usually we stain samples for immunoglobulins, that is IgG, IgA, IgM. And for complement, usually C3, sometimes C4, and also we chain for light chains, so kappa and lambda chains. And based on the pattern of what is getting stained, we can get an idea about what the disease mechanism is. For example, you can see here on the left-hand side, this patient has all the immunoglobulins, IgA, IgM, and IgM, as well as complement. So this is an immune complex mediated disease. In the middle photograph, you can see there are no immunoglobulins, but there is only complement. So there's dominant complement staining. This can be a C3 dominant glomerulopathy, or if this had been C4, a C4 dominant glomerulopathy. And in some instances, you can have this membranoproliferative pattern, but neither C3 nor immunoglobulins, in which case it is negative for complement and immunoglobulins. Right? So this gives us a better idea about what the mechanism of injury is. And based on this, the new guideline divides membranoproliferative glomerulonephritis into 3 categories. So positive IgG with or without complement is immune complex mediated, complement dominated is complement mediated, and negative for Ig or complement 3 is another entity. Generally, this encompasses thrombotic microangiopathies. So how is this useful? It's useful because it tells us what we need to look for in terms of coming to identifying a secondary cause for these glomerular diseases, and in turn that will help guide the management. So if you have immune complexes, your next step is to see, are these monoclonal deposits or polyclonal? And if it's monoclonal, how do we identify that? By staining for kappa and lambda chain. So if you have both kappa and lambda being stained, this is polyclonal. Whereas if you have only kappa or only lambda being stained, this is monoclonal. So if you find that it is light chain restricted, then you have to look for a clone, which is leading to this monoclonal gammopathy. If it is polyclonal, then you have to look for infections or autoimmune diseases. And idiopathic is probably basically something we cannot identify yet. If it is complement dominated, it can be either C3 or C4, and we don't generally test for C4 here, so we might detect C3. Most common cause of C3 is again post-infectious, but if you have excluded post-infectious GN, then there can be abnormalities of the alternate complement pathway. So this approach was first identified in membranoproliferative glomerulonephritis, but what I feel is that this signifies more a trend in our approach, our understanding of glomerulopathies. And you can see this other KDIGO guideline or document, which describes a pathogenesis-based approach to glomerulonephritis in general. So not just MPGM, but any kind of proliferative GM. And again, you can see the same entities coming up. It could be immune complex mediated, it could be pauci-immune, it could be anti-GBM, it could be monoclonal, or it can be complement mediated. So by using this kind of pathogenesis-based approach, it's easier for us to know what we need to look for next, what are the underlying causes we should look for, and then in turn to guide our management. So perhaps rather than doing light microscopy first, or rather than prioritizing light microscopy first, IF is going to become our first step in diagnosing glomerulopathies. That does not mean light microscopy is not important, it is very important. But IF may give us a better clue as to the underlying etiology. So moving on from the diagnostic trends to some slides about the general management, I thought I'd focus about anticoagulation here before moving on to more specific entities. So as you all know, nephrotic syndrome is characterized by a higher thrombotic risk, and that risk is higher in membranous nephropathy. And the more severe your hypoalbuminemia, the more severe your proteinuria, the higher your risk of thrombosis. And venous thrombosis is much more common than arterial thrombosis. So the news is that now there are more objective tools available which we can use to stratify patients according to the risk of thrombosis versus the risk of bleeding if they are started on an anticoagulant, and we can use that to guide our decision making. So these calculators are available online, and what was on the previous slide was the link, and that is incorporated in the guideline as well. So what I've done here is I put in some details of a fictitious patient to calculate the risk score for thrombosis. So this The risk factors for thrombosis that are considered here are basically only hyperalbuminemia. So that we have to keep that in mind. So they haven't considered things like obesity, immobilization, which will also add to your risk. And the risk factors for bleeding that they have considered are from this atria calculator, which was used in atrial fibrillation. And they have considered risk factors like the renal function, hemoglobin, prior history of hemorrhage, and hypertension. So they have not considered things like risk of falls and frailty. So this can be a guide, right, to decide on whether the patient will benefit from anticoagulation. But there are other factors that we need to consider as well when we are deciding on whether to anticoagulate a patient. So this particular risk calculator is only for membranous nephropathy. Similarly, if there is severe hyperalbuminemia plus other risk factors, we can consider anticoagulating in other forms of nephrotic syndrome as well. Okay, so moving on to more specific management. Changes that we see in the specific management are change in focus. So now patients with glomerular diseases are living longer because they have better treatments. If they are living longer, we need to prioritize minimizing long-term toxicity. So one of our aims is to minimize steroid exposure. How do we do that? We can use lower steroid doses, and there may be a place for steroid-sparing agents. Some of the things that have come up are rituximab and C5a inhibitors. There are some novel agents and novel approaches as well. So I'm going to talk about lupus nephritis and ANCA-associated vasculitis. In lupus nephritis, I'm focusing on class 3 and 4 lupus nephritis because that is what is most associated with adverse renal outcomes. So when we have a patient with class 3 and 4 lupus nephritis, our first thing is to look at the biopsy and see whether there's active disease or whether this is chronic disease. If there's chronic disease, there's no point in immunosuppressing. Our management is supportive. If it's active disease, then we need to immunosuppress the patient. Otherwise, the risk of progressing to end-stage kidney disease is high. So what are our options? Steroids along with another immunosuppressive agent. So traditionally, we use MMF and cyclophosphamide, right? Or cyclophosphamide, sorry. And the newer guideline brings up the potential for calcineurin inhibitors as well as B-lymphocyte targeting biologics. So let's look at them in a bit more detail. First-line agents still remain cyclophosphamide and MMF, right? Our main worry with cyclophosphamide is the risk of toxicity, the risk of malignancy with higher cumulative doses, and risk of ovarian cancer. And generally, adverse effects are more common with oral versus IV. So when we talk about about cyclophosphamide, we are talking about generally IV therapies. We don't generally use oral. There are two regimens for cyclophosphamide, high dose and low dose. And again, because of toxicity and because of some evidence from trials which show that they are similarly efficacious, we use low dose IV cyclophosphamide as the first line. And in fact, cyclophosphamide is the only treatment which has shown long-term follow-up data with the demonstrable improvement of renal survival. So the points to consider are that the low dose treatment has strong evidence only from white populations and not in patients with very aggressive kidney disease. So if there is a rapidly deteriorating renal function, we may still opt for high dose IV cyclophosphamide. However, MMF is a popular alternative and it is more and more commonly being used in preference of cyclophosphamide. Why? Because of these risks of toxicity. So often lupus nephritis affects young females, so we don't want them to be at risk of infertility. Also, if there's prior cyclophosphamide exposure, we don't want to increase the cumulative load. And again, because of this issue of low-dose cyclophosphamide having been used in white populations, in other ethnicities, there may be a move towards using more MMF. So CNI inhibitors and biologics are also becoming more popular. CNIs are being used in the context of triple therapy, that is prednisolone, MMF, plus a CNI. So there's evidence for a regimen with tacrolimus, and there's evidence for another regimen with voclosporin, which is a novel kind of calcineurin inhibitor. So the data is promising, but these are still recent studies, and there is no long-term follow-up. And we know that calcineurin inhibitors have toxic effects also. And one of our priorities now is minimizing toxicity. So there's nephrotoxicity and there are lots of metabolic side effects as well. So still these are not first line, these are third line agents. Rituximab has been popular as a biologic agent, but it has not been proven efficacious as a first-line induction agent. Its place is mainly in refractory disease or as a steroid-sparing agent. And then there is the new belimumab, which is a B-lys inhibitor, and it can be added onto cyclophosphamide and MMF for better remission rates. But again, there is no long-term follow-up yet. So that's about the induction agents. What about steroids? So one of the new characteristics is our movement towards using lower doses of steroids. And these charts are from the guideline. And so you can see they have advocated different kinds of dosing schemes. And there's a very low or reduced dosing scheme on the right side here. So these low dosing schemes, you can see they start with IV methylprednisolone, 250 to 500 milligrams per day. And then moving on to a lower starting dose of oral steroids. This could be about 25 milligrams per day, and tapering very rapidly to low doses of about 2.5 milligrams by 12 weeks. So this regimen was used in this triple immunosuppression therapy trials, and it was effective, right? So, but these particular standard dose and reduced dose regimens have not been directly compared with each other. So still the guideline doesn't say, move towards a reduced dose scheme. There's no recommendation as such, but it's very promising to see that low dose steroids seem to be effective, and maybe there's potential for the future. With regard to maintenance therapy in lupus nephritis, things haven't changed much. So still we continue the lower levels of steroids along with another immunosuppressive agent. MMF remains the first-line therapy of choice. If the patient can't have MMF because of intolerance or pregnancy being planned or cost and availability issues, then azathioprine can be used. If neither of them can be used, there's still a place for a CNI inhibitor. So how long should this be for? Duration, at least 36 months, including the induction phase, is the current recommendation. Okay, so that's about lupus nephritis. Moving on to a few slides on ANCA-associated vasculitis. There's been a lot of new studies come up in this area over the last few years, especially considering that the latest guideline was from 2012. And one of the key features that we see is more and more rituximab being used. So let's just have a closer look at what's going on. So when it comes to induction therapy, one therapy is steroids, and the other therapy is, along with steroids, we give another second agent. So first-line agents recommended in the guideline are rituximab, cyclophosphamide, or a combination of rituximab and cyclophosphamide. There's a small place for MMF, but it is not very effective. I have just included it here. So if we think of rituximab, that is the treatment of choice. It is preferred in children, adolescents, concerns of fertility, so basically the younger age group, and then the frail elderly. So almost everybody is included in that category. However, the evidence for rituximab comes from the RAIL trial, where they did not include patients with creatinines more than 4. So if there's very severe kidney involvement, we still have to use either cyclophosphamide or a combination of rituximab and cyclophosphamide. Its preference for rituximab is not only pushed by the reduction in side effects, but there is some post-hoc data from the RAIL trial which shows that it might be more effective in relapsing disease, and patients with PR3 positive disease might have fewer relapses if they are given rituximab. So there are various regimens that have been used in the trial, which I have listed here. Evidence for IV cyclophosphamide comes from the Cyclops trial, and it is a dose of 50 milligrams per kilogram given as 2 weekly doses 3 times, followed by 3 weekly doses up to 24 months. And then there was this combination treatment of rituximab with cyclophosphamide, the thinking behind it being that it would allow a lower dose of cyclophosphamide and lower toxicity. And there it was compared with IV cyclophosphamide with similar effect. And these were the regimens that were used in the trial. So Plexivest trial came out last year, and it was a very important trial in ANCA-associated vasculitis, one of the largest trials. And it asked 2 questions related to the use of plasma exchange and related to the use of a lower dose steroid regimen in patients with ANCA-associated vasculitis with renal involvement or diffuse alveolar hemorrhage. And they randomized patients to either receive plasma exchange or no plasma exchange, standard steroids or low steroids. What they found was that when it came to the primary outcome of death versus end-stage kidney disease, there was no difference whether the patients got plasma exchange or not, or whether they received standard dose steroids or not. And there were fewer side effects in terms of infections in the lower steroid group. So what they did suggest is that plasma exchange may not really have much of a place in ANCA-associated vasculitis. However, the guideline is still a little bit careful about saying that plasma exchange has no place at all. They still do recommend that if the creatinine is more than 500 or there is severe diffuse alveolar hemorrhage, that plasma exchange can be considered. What about steroids? These were the regimens used in the PEXIVEST trial, right? So that trial compared standard dose with reduced dose steroids. And you can see here, so if we take average patient being started on 60 milligrams of prednisolone per day, halving the dose by the second week, right? And then tapering down to doses of about 5 milligrams by 15 weeks. So this is something we're not very used to doing, but in this trial, they showed that it was similarly efficacious and had fewer side effects. So this is something that the guideline promotes. So talking about steroid sparing, there are some new kids on the block. Avacopan is a new drug. It's a complement 5A inhibitor, which was studied in the Advocate trial. And it was effective as a steroid sparing agent. So they compared patients who had been induced with rituximab or cyclophosphamide, were given either steroids or avacopan, and they found that the avacopan group did better. However, there was quite a rapid steroid taper in the control arm, which is probably not our usual practice. And of course, avacopan is an expensive drug. So whether it will come into use and when it will come into use is questionable. These are the options we have for maintenance. So once we have induced, we have to maintain patients in remission. So again, this guideline is focusing a lot on rituximab. Alternative is azathioprine, and again, MMF coming far behind as a third contestant. So rituximab, the advantage is it can be used as monotherapy without steroids as opposed to azathioprine, and studied up to 18 months so far, azathioprine generally up to 4 years. So these are the studies, RITSAN and RITAZAREM, which compared rituximab and azathioprine. And what they found was that rituximab had fewer major relapses, which is why it is preferred over azathioprine. So these are the regimens that are proposed. So regular infusions of rituximab if you're using rituximab as maintenance, and for azathioprine, generally continue the dose up to 4 years with a reduction over that period of time, along with steroids. So here you can see generally again rituximab being preferred for maintenance, and these are the reasons. Almost everyone you would prefer rituximab, and azathioprine basically if you don't want to give rituximab. So low baseline IgG, hepatitis B exposure, and limited availability of rituximab. That's where we will probably fall in. So a word of caution is that we don't have a lot of long-term experience with rituximab as maintenance therapy, and there's a risk of hypogammaglobulinemia. What about relapses? So again, in severe relapses, we can consider...
Sorry for that. There's a disconnection between Diluxi and us. Thank you very much, Diluxi, for your informative and interesting presentation. I think she's back, so we can continue.
There's had a problem with my connection. So in summary, we've discussed the diagnostic approach and some management issues that have been highlighted in the new guideline. And thank you. I'll be happy to answer your questions in the discussion.
Thank you very much, Diluxi, for the excellent presentation. So we can move to the third presentation now.
Good afternoon. Now I call upon Dr. Brahma Thangaraja. He is going to talk on evidence-based lifestyle change to safeguard the kidneys. Brahma, well-known person, is the enthusiastic nephrologist going to already started the kidney transplantation in Jaffna, cadaveric transplantation, successful first transplantation, the patient doing very well. We are very thankful to the nephrology team and the vascular team to initiate the step to start the kidney transplantation in Jaffna. Dr. Brahma, no need further introduction. Now we call upon Dr. Brahma. Over to you.
Good afternoon, everyone. Thank you for the introduction, and thank you for the hospital community and all the consultants for supporting us throughout. The topic that is given to me or that I chose for myself is evidence-based lifestyle changes to safeguard kidneys. It's hard to adapt a lifestyle change. It's harder to sustain a lifestyle change, even harder to assess and ascertain a lifestyle change, which I'm going to try today. Imagine if I had a 50-year-old diabetic patient who had been a diabetic for 15 years with renal impairment, serum creatinine of 3.6, probably with a proteinuria of 2 grams. And he had not visited the clinic for 4 consecutive sessions. What could have had happened to him? Probably he could have got enrolled, or maybe he prefers the native treatment, and he might come up very, very late with end-stage renal failure. Maybe he got himself transferred to a better unit which provides a better outcome and dialysis performance. He might have got confused with our statistics of how much of survival do we have in our dialysis unit. Could have possibly, yes. Maybe he had worsening renal impairment and got himself transplanted. Or he could have initiated the dialysis somewhere else. The answer would be, likely, the life would have had its course. A patient, or about 50,000 patients were followed up in US in 1996 to 2001 in a real clinical scenario with CKD, with multiple comorbidities. Throughout the different categories of CKD, the death is the likely event that could happen. And the chances of death increases as the CKD stages progresses. You can see, when you see the CKD stage 4, the people died before initiation of dialysis is double the population of whom we dialyze. The message is, safeguarding kidney is safeguarding life. So is it a dead endpoint? Can we reverse it? A patient has got advanced CKD. What are we going to do? So we see the Kimmel-Wilson nodule. Then second picture would show some mesangial hypercellularity. And third, after 10 years, a normal-looking kidney. Is it possible? We would have been taught otherwise. A normal-looking kidney would happen. Then after 5 years, the mesangial hyperexpansion would happen. Then the nodularity would take place. Could this possible? This could have happened? It could have happened if you had maintained the normal glycemia in the view of pancreatic transplant. This is very enticing and intriguing. In 2003, 13 patients, 2003 to 2010, 13 patients were follow-up who have had pancreatic transplantations. And although all of them had that remission from the diabetes, and they were diabetic-free. And they were looking at the renal functions as well. They had different degrees of renal involvement at times. They did the biopsy. They did the biopsy at 5 years' time. They were all normoglycemic. They could not see much changes. Still, the nodularity was there. Still, the basement membrane was thickened. Still, the mesangial proportion was high. But there comes a surprise after 10 years. 10 years of normoglycemia, 10 years of perseverance, then you will see the nodularity has come down. Global basement membrane has thinned down. And the mesangial proportion has come down. We are reverting the kidney. But the lesson learned here is you need to persevere for longer time. It could be decades. Then we have come into an onset of very severe renal disease. Can we prevent the renal disease from happening? Can we prevent the risk factors or the commonest reason for the renal failure, that is diabetes? Can we reverse the type 2 diabetes? There are instances now, and there is an interest in reversing diabetes. And it's well proven in obese patients who have got BMI more than 40, and patients of BMI more than 35 and comorbidities who undergo bariatric surgery. And definitely 60% render themselves diabetic-free in the first year, and that would persist up to 4 years, and they would be diabetic for 40% of them would be diabetic-free. And the standard of care when you get diagnosed with diabetes would not give you that. But if you would go beyond the standard of care, and you should be able to provide the best care for the patient in selected group of patients who are recently diagnosed with diabetes, who are not on insulin, and who are younger. If they are put into a regime of low-calorie diet and very low carbohydrate diet, 10% of them could sustain a diabetic-free interval as well as the onset of kidney disease at least for about 4 to 5 years' time. This is very appealing, but please note that we need to go beyond the standard of care to deliver with diligence. Then we try to prevent it. We can't prevent it. The diabetes has taken place, and you are a diabetic patient, and you are obese. And we want to control things. So there is a good study, the Look Ahead study. It looked into about 250 patients, and they want to aggressively control the weight reduction. They went into intensive lifestyle modification, and they reduced HbA1c, they reduced the weight, but end of 4 years, the endpoint was look into cardiovascular deaths, but they couldn't achieve that. But mind, they had better lipid control, they had better diabetic control, they had better biochemical control. Could this be because they looked into only one aspect of weight reduction? Could this have been different had they looked into intensive reduction of weight, intensive control of blood pressure, intensive control of lipid profile, intensive control of all the comorbidities? Then, if they had waited for decades, it's likely they would have had the mortality benefit as well. This is very much reflected in the study that's done in Sweden, where they looked into diabetic patients, 200,000 diabetic patients, compared with 1 million of patients in the real clinical scenario. They control salient aspect. They control the blood pressure. They control the diabetes. They control the cholesterol. They control the albuminuria. And they also controlled and made sure the patients are on a smoke cessation. And the outcome was the death or cardiac mortality, if all these 5 factors are controlled, would that be of a normal population? Irrespective of your age group, or marginally elevated cardiac mortality rate. But if you would fail to control one of the components, the risk would increase. If you fail to control 2 of the components, the risk would further increase. And if you fail to control all 5 components, it will be further increase. But surprisingly, if you look at it, a person who has been on these 80s and all 5 components were not controlled, but or the person who has been on 50s, all 5 components were not controlled. The danger is more for the person who is at a younger age. I will leave that question for you all to answer, and there is an explanation for it as well. So if we would control all the parameters, we would be able to control it. That is again reflected in Eric's study, where they looked into kidney-specific components. If you component 1 of 7 factors, adding the exercise and adding the diet, your risk of CKD would reduce by 10%, and incrementally decrease, the risk would be controlled if you keep on controlling all 7 parameters that is suggested by American Heart Association. Then we know if we would control the multiple factors for the prolonged time, and we should be able to achieve it. The evidence is much vast in regard to salt restriction. Salt restriction is shown to reduce the blood pressure. It's shown to reduce albuminuria. It's shown to retard the progression of CKD. But I'm not surprised, it has not yet shown to reduce the cardiovascular mortality. Has it been measured as an individual ailment? But The options are very much open if we are going to control it as a group of risk factors. Here, the concept is not interesting, how we are going to implement the contrast. Here is a good study that was done in Birmingham, UK, where they identify the Bangladeshi people would have high salt excretion, as well as that would suggest a high salt intake. And just advising them cut the salt would not help. So they brought in the people who make the dinner, lunch, and breakfast at home. They taught them different recipes, and they proved them they could be done. And in turn, you could reduce the blood pressure, you could reduce the proteinuria, and definitely you can retard the progression of kidney disease. Same thing that applies for restriction of proteinuria as well. I would bring your attention to the first graph, which shows when you introduce a low-protein diet, there is a sudden decrease in the EGFR. Isn't that surprising? Or isn't something that is very familiar? We have seen that is in ACE inhibitors. We have seen that in the talk with gluten inhibitors, dapagliflozin. As soon as you introduce the drug, there would be a reduction in EGFR. That kind of a similar reduction could be attained by low-protein diet as well, because the vasodilatory effect of protein is inhibited, and you will get a vasoconstriction, and the EGFR would go up, but the sustained remission would benefit from having a long survival for the kidney. This protein diet could be further added to your routine protein reduction as well. Then what about very low protein diet or vegetarian diet with supplements? It has further shown that when the EGFR is below 20, and if we can look into the nutritional aspects, and if we can look into the micronutrients, and if we would control to a lower protein diet, we can retard the progression on onset of dialysis. The number needed to treat when the EGFR is less than 30 would be around 20, but when it comes to 15, the number needed to treat would be 5. So it's a drastic, you need to treat 5 people with very low protein diet to offload or retard the onset of the dialysis itself. So that has definitely proven on its own, but again, it has not shown a cardiovascular benefit. But take in account, we are going to play all the factors together. This is again applies to the exercise as well. I will not be taking much of the time in regard to exercise. Exercise alone would prove benefit in blood pressure control and protein reduction and retardation of progression, but would, in combination of other factors, it's likely to reduce the cardiovascular mortality as well. So we are going to play all the factors together. How are we going to bring in a behavioral change? Could there be a scientific model to do that? Could we identify the behavioral change technique? And that technique, what is the intervention that we are going to do? And how are we going to sustain? A patient comes with overweight. I'm going to set a goal to say 3 kilograms in 3 months duration. I'm going to recommend the patient to buy a weighing scale for self-monitoring. I'll introduce and talk to the wife, as well as to say the family needs to bring in the weight together and set the targets together. Restructuring, I might advise him to buy an activity index, maybe an iPhone watch if he can afford it. Then we will educate the patient and persuade the patient to lead it and show the benefits, not just the weight reduction, the overall benefits for it. And if he succeeds, he can lead the next team as well. And we need to sustain this with the program that needs to be established in a hospital level for a diabetic control, blood pressure control, weight control, and we could achieve this and sustain it for the benefit of the population as well. But generally, in the clinical practice, what do we practice? We go for a didactic approach and leave it to the patients. I give you a piece of advice, and I give him a leaflet, and patient at the mercy to discern whatever the information that could discern. And it's generally, if he's going to force me, I'm going to give him some very complex answers. And at times, I'm going to be very restrictive and say, don't eat protein, don't eat fruits at all, which is illogical, and we need to rationalize it. And I would be very much insensitive to his familial circumstances as well as the social circumstances. And at the end of the counseling, I would make him feel guilty as well for not cooperating with me as well. So this needs to be changed into an approach where you have a collaborative problem-solving approach. Whenever you say something, don't eat this, always say what is the meal equivalent for that. And we need to train and graduate the family as it was done in the Bangladesh study to get them into a behavioral change. And I'm not going to stop it over there. The social, the lifestyle changes are not just for the patients, it's for the doctors as well. And it's for the administration as well. So we're going to set a target, renal replacement treatment for everyone by 2025. And we want to have a fork and wheel model of service provision, where the wheel would be spinning, swirling smoothly based on the swivel that's based in Jaffna Hospital. And that would have a distribution that will lead to an improved delivery of health services, improved access of health care, improved utilization of care services, increased equity, and moreover, patient satisfaction. And we need to start a system where we will have an early referral system, where morbidity and mortality would be reduced, and hospitalization would be reduced, AVF-related complications would be reduced, and the mortality and morbidity and dialysis preparedness would be improved had we referred the patient in time to the renal services. And this is what the summary that I've put in the center would be treatment of the underlying disease as well as the comorbidities with a low salt diet, with low protein diet, when needed, when EGFR is further going, very low protein diet with dietary input, moderate exercise, and early referral, and through that empowering the patients to safeguard the kidney and safeguard the life. Thank you.
For informative lecture. And now this is a time for the question.
Yeah, I'm bound to ask questions. This is the question to Delushi. So I'm very glad to see that we have been practicing immunosuppressive regimen that's purported in the guidelines even before the guidelines were in practice. So I'm happy to see that's been practiced even before the guidelines were in practice. The question is the cyclophosphamide dosage. Even though the cyclophosphamide dosage says a twice weekly regimen, how practical, and is it a bit of a higher dose for our population? In the sense, the twice weekly regime of 500 milligram lower dose for 6 doses, and very frequently we witness people who go profound bone marrow suppression, and it has not been an isolated case. I think we have seen very many cases. And we do have a modified regime where we go for a cyclophosphamide, the monthly regime of 500 or even low. And to an extent, it has not been substantiated with good response. Is it the same that you all see in Colombo, or is it something regional variability?
So I don't think we've seen anything like that in Colombo. What we practice is 5 milligrams twice weekly, 6 doses for, you're talking about SLE, isn't it? So the Urolupus regime. We don't use the high dose regimen actually, and even if patients come with severe renal function, when we adjust the dose according to the renal impairment, often the dose becomes less than 500 milligrams. That's what we have noticed. I don't know if we have enough evidence to compare a lower dose versus the normal dose, but in practice, we don't see a lot of cytopenias with the Urolupus regimen, at least in Colombo.
It makes sense. What we do is we don't use the high dose, we dose the lower dose, but the frequency that of a higher dose, maybe a monthly involvement, or maybe at the highest level of disease activity, we might prone to give it maybe a second or third dose. But that might be the teaching from Kandy, I believe. Rajitha, do you agree, or is it different in Kandy, or I have learned it long in Kandy?
No, I also agree with Delushi because the low dose Urolupus, the experience is the same. Hardly you'd get, I mean, not so much you would get the cytopenias related to that. So, I mean, we also tend to continue with the Urolupus trial of once in 2 weeks, the 6 passes for the initial period of lupus nephritis induction.
And this is a question for Rajitha. Is there any indications for spironolactone for diabetic nephropathy?
Yeah, so good question. I'll take it like this. So now we are, like I showed in the presentation, now we have a lot of evidence coming out with the mineralocorticoid receptor antagonists. But it needs to be noted that this is not the spironolactone mineralocorticoid that we know. So the spironolactone is a steroidal non-steroidal mineralocorticoid receptor antagonist, whereas here they are talking about steroidal mineralocorticoid receptor antagonists. So Finrenone is the drug that they have trialed in a lot of these trials, which has shown a lot of benefits. So this is a non-steroidal, sorry, I made a mistake. This is a non-steroidal MRA. And the action, the site of action, the level of binding, the efficacies are completely different to what we see with spironolactone. So we don't really have much evidence to say that the spironolactone would has the same efficacy and the benefits. Therefore, spironolactone will not come into guidelines in such a way, and also because it's now generic, nobody's going to do trials on spironolactone anymore. But in a situation and an environment where we don't have the newer MRAs, you can always try the spironolactone, and because at the end of the day, it works on the same pathways. So there might be some efficacy of it, even though we don't have a lot of benefit from it. Earlier days, before these trials came up, there were a few trials showing once you combine spironolactone, the group of mineralocorticoids, into your ACE inhibitors and your the delta SM group of calcium channel blockers, there will be some proteinuria reduction and benefit, but it hasn't really translated much into outcome benefits in a major scale to come into guidelines. So in a nutshell, the answer would be spironolactone, we don't know, but it's the newer MRAs that are showing benefit. But in a situation where you don't have the new MRAs, you can certainly try the spironolactone. But keep in mind, you need to be very cautious about the potassium, especially in CKD populations, because the tendency for hyperkalemia is much higher with spironolactone compared to the newer MRAs.
Thank you, Rajita.
Just one more question. I feel bad not asking you a question, Rajita. So you said there are different phenotypes of diabetes that's been evolving. So one of the few phenotypes we are seeing is extremely high proteinuria with nephrotic syndrome, which goes into a syndrome of rapidly progressive diabetic nephropathy, where they end up being end-stage renal failure within months, maybe 6 months to 1 year. And the same, the other spectrum is we see patients with interstitial nephritis with severe inflammation, which is again rapid, progressively goes on, and the patient ends up being in dialysis. At times we have tried even to see whether there are any superadded pathologies, and very, very many times we don't find any. Do you have any management strategies, or you have any insights in which we could solve this crisis?
No, I agree with you, Brahma, because I think, in the Western world, I don't think the disease pattern is the same as what we actually are seeing in the Asian, South Asian countries, especially India, Sri Lanka, where, like what you mentioned, there is a group of patients who are profusely nephrotic and with renal impairment in their renal functions, and where it just, relentlessly, they just progress into end-stage kidney disease. I think part of it is due to the initial level of control in most of these patients, because these patients are generally more young patients who've had very aggressive diabetes to start off with, which hasn't been really attended to initially. And we've been shown through a lot of studies that the initial control makes a huge difference in the outcomes of these diabetic kidney disease patients, and it sort of tends to have a legacy effect. You get the initial few, months to years well controlled, then the long-term outcomes are much better. So with regards to the initial management, what I could suggest is, if you find these patients, most of them wouldn't present to the nephrology services, unfortunately. But in whatever services they present to, if the initial control can be really strictly, achieved, that might actually translate to a lot of benefit. But once they develop this profuse level of nephrotic syndrome, we can certainly try the newer medications, especially the SGLT2 inhibitors seem to have a lot of benefit in this group of patients because it reduces the interglomerular pressures. And we can certainly add on the ACE inhibitors, and hopefully in the coming years, we might get the MRAs coming into Sri Lanka. We can certainly add on those to improve the glomerular hemodynamics, which might reduce the progression. But beyond that, it's like what you mentioned in your presentation, tight control of all the parameters are the ones that's going to make a difference. And just one sentence about what you mentioned about the interstitial component. A lot of our patients lose a lot of native medications, which they don't really come out with or tell us. So that also plays a part in this interstitial component. Apart from diabetes, there is that component also contributing to the interstitial nephritis.
The last question, the patients with the chronic kidney disease, the main culprit is the proteinuria and the high blood pressure to deteriorate the kidney function fast. The patients we usually treat with ACE inhibitors and angiotensin converting enzyme inhibitors. If there is a contraindication, is it possible to use the drugs beta blockers like bisoprolol to reduce the proteinuria?
Yeah, so yes, so one of the tricky situations is where you have patients where we can't use these agents for their benefit. But unfortunately, we don't have much evidence of benefit in proteinuric conditions with regards to beta blockers, or for that matter, alpha blockers or centrally acting agents. However, the more important thing in these patients with CKD and proteinuria is having good blood pressure control. So if whatever the agent that we use, the first thing needs to be to achieve a good blood pressure control. And then only we should be starting to target the proteinuria control and everything, because without blood pressure control, we can't achieve anything else. So in those situations, any agent that will get the blood pressure control under coming to its targets, lower the better, certainly we can use. But whether it has benefit over the ACE inhibitors or almost the same benefits, we don't have evidence, and it has not been shown that other agents have the same efficacy.
From audience, any more questions? In the absence of further questions, we are going to conclude this symposium. Thank you very much for all three speakers who gave a good information about control of kidney disease. Thank you very much.
Thank you very much. Thank you for the opportunity.